It's time for another warm-up review. Let's get going. A woman develops intense muscle cramps and darkening of her urine after exercise. What is the most likely diagnosis? So this is pretty classic for McArdle disease. Next, which personality disorder best fits each of the following statements? So sense of emptiness and loneliness and impulsiveness, this is a characteristic of borderline personality disorder. Next, we have odd appearance, thoughts, and behavior. No psychosis, though, and social awkwardness. This is going to be schizotypal. Next, we have controlling, perfectionistic, orderly, stubborn, indecisive. That's going to be obsessive compulsive. And then criminality, unable to conform to social norms, disregard for the rights of others. That's going to be antisocial. Next, what substances cause hemolytic anemia in patients with G6PD deficiency? So the mnemonic here is spleen purges nasty inclusions from damaged cells. So that stands for sulfonamides, primaquine, nitrofurantoin, isoniazid, favabeans, dapsone, and chloroquine. All right, that's it for the review. Let's get to that lecture now.
Before we get started, I need to address the elephant in the room. Facial hair. Now, I'm not sure why this has become such a controversial subject. First of all, Dr. Lewis struts around here like he's the king of DIT, all because he has a beard. Fine, whatever. And then Dr. Taj Mahal, I can't ever say it. What's his first name? Elmo? Email?
Emil Tajoy.
Dr. Emil Tajoy. Sounds like a third-rate Bond villain. Anyway, Dr. Oddjob comes along and he starts talking trash about his beard, which is fine. Everybody needs a gimmick, I guess. And I'm really happy for him, and I'm going to let him finish, but back when I grew a beard, I had one of the best beards of all time. All time. So, if you have to vote on who has the best beard, I think it's pretty clear who wins. Now, in this video, we're going to talk about platelets. We're going to start by reviewing how platelets work, and then we'll review some drugs that affect platelet function. Platelets work hand in hand with the coagulation cascade to produce hemostasis. But we're going to be talking about platelets separate from the coagulation factors so that you can keep those somewhat separate in your mind. So let's start with some platelet basics. Platelets 101. First of all, platelets are derived from precursor cells called megakaryocytes. Remember, megakaryocytes are huge. They're megakaryocytes. And then they pinch off little bits of cytoplasm and cell membrane, which are the platelets. Now, platelets have no nucleus, and they live in circulation only 8 to 10 days. It's tempting to think of platelets as these little inert fragments that don't really do much but plug up holes in blood vessels. But in reality, they're a lot more complex than that. They have several different kinds of glycoprotein receptors, and they contain granules filled with various signaling substances. There's actually a lot going on with the platelets, especially when you consider that since they have no nucleus and no DNA, they can't make any proteins. So let's talk about how platelets work, how they stop bleeding. Platelets work hand in hand with the coagulation cascade. And remember, the end product of the coagulation cascade is a fibrin clot or fibrin mesh. That fibrin clot is the more permanent blood clot. But that takes a little time to form, so the very first step in hemostasis is the formation of a platelet plug. So first you plug the hole with platelets, and then the second step is to activate the coagulation cascade and form the fibrin mesh clot. But the platelet plug comes first. Think about it, if you're in a boat and it springs a leak, the first thing you do is plug the hole quickly, and then you can worry about a more permanent patch. So let the phrase platelet plug remind you that the platelets act first to plug the hole, and then the fibrin mesh is that permanent patch. So when you have an injury to a blood vessel, that leads to platelet adhesion, then platelet activation, and finally platelet aggregation. Adhesion, activation, and aggregation. So first the platelets have to adhere to the injured surface, then they have to become activated, and then they aggregate and clump together to form that temporary platelet plug. So it's important to understand each of these steps, so we're going to talk about each step in detail. So start by looking closely at how platelets interact with the vascular endothelium, the endothelial cells that line the inner surface of the blood vessels. Those endothelial cells contain a lot of important chemicals that play a role in platelet stimulation and thrombogenesis. There's von Willebrand factor, there's thromboplastin, also called tissue factor, there's TPA, which is tissue plasminogen activator, and there's PGI2. But for now, let's focus on von Willebrand factor. Take a look in your study guide. Von Willebrand factor is made up of several subunits that are linked by disulfide bonds, and it's synthesized by endothelial cells and megakaryocytes. Now, we just talked about how megakaryocytes are what make platelets. So platelets have von Willebrand factor inside them, as we're going to see shortly. Then, von Willebrand factor has two major functions. First of all, it complexes with factor VIII and stabilizes it. So a deficiency of von Willebrand factor, which we call von Willebrand disease, is going to look a lot like factor VIII deficiency, which can lead to elevated PTT. And what disease results from factor VIII deficiency? I'll give you a hint. Remember that 8 sounds like A. It's hemophilia A. So just like hemophilia A raises your PTT, so can von Willebrand disease. Then the other major function of von Willebrand factor is that it's involved in platelet adhesion to the vessel wall and to other platelets. This means that deficiency in von Willebrand factor will also lead to an increase in bleeding time. Bleeding time is a test used to measure platelet function. Now, we don't really do bleeding times much anymore, but the basic idea is that you cut the skin and you see how long it takes for the bleeding to stop. Since the platelet plug is what stops the bleeding initially, the bleeding time is a test of platelet function. So bleeding time will be prolonged in anything that impairs platelet function. But again, von Willebrand factor is important for both the coagulation cascade and also for platelet adhesion. So if there's a von Willebrand factor deficiency, the platelets can't adhere to the injured endothelium and they can't form that platelet plug, so bleeding time will be prolonged. All right, so going back to our blood vessel, the thing that kicks off thrombogenesis is some kind of injury to the vascular endothelial cells. When the endothelium is injured, the subendothelial collagen is exposed, and you have some platelets just kind of floating by. Now, when the endothelium was injured, von Willebrand factor and all those other chemicals leaked out of those damaged, ruptured endothelial cells. But we're still focusing on von Willebrand factor for now. Von Willebrand factor is going to bind to that subendothelial collagen. Then it's also going to bind to a glycoprotein receptor called glycoprotein 1b on the surface of the platelet. That's how the platelets begin to adhere to the damaged endothelium. So injury leads to platelet adhesion. The next step after platelet adhesion was platelet activation. And that basically means that the platelets change shape and they grow these long fingers or pseudopods that help them bind tightly to the injury site. And then activated platelets begin secreting lots of important substances. We talked about all the stuff that was found inside the endothelial cells, but remember there's lots of stuff inside the platelets too. Remember, platelets don't have nuclei or a lot of cellular machinery, so they can't make anything, but they come preloaded with several important chemicals. They have von Willebrand factor again, and also some fibrinogen, cyclooxygenase, thromboxane A2, and a lot of other chemicals. These are actually outlined in the study guide under platelet stimulation. The first bullet is adhesion, which is just the first step of platelet stimulation. We just covered that. Then the second bullet is activation. So activated platelets secrete a bunch of stuff. They secrete ADP, platelet-derived growth factor, serotonin, fibrinogen, lysosomal enzymes, thromboxane A2, which, as you remember, is a prothrombotic substance that's going to induce thrombosis. It's right there in the name, thromboxane. Platelets also secrete calcium, which is needed to activate the coagulation cascade. Several steps in the coagulation cascade require calcium. And platelets also secrete thrombin. And remember that thrombin is the enzyme that converts fibrinogen to fibrin, and fibrin is what forms the fibrin mesh clot. And when the platelets release thromboxane A2, that leads to vasoconstriction and platelet aggregation. So thromboxane A2 comes from platelets, and it also induces further platelet aggregation. So besides forming the platelet plug, activated platelets also release a lot of things that are necessary components of the coagulation cascade, such as fibrinogen and thrombin and calcium. So we had adhesion of platelets, then activation of platelets, and now we're ready to talk about aggregation of platelets. I mentioned a second ago that one of the things that the activated platelets secrete is ADP, or adenosine diphosphate. And on the surface of the platelets, there's an ADP receptor. And when ADP binds to that receptor on the surface of the platelets, it triggers the expression of a glycoprotein 2b3a to come from inside the platelet to outside the platelet. So the ADP receptors basically tell the platelet to start putting glycoprotein 2b3a on the surface of the platelet. 2b3a is very important in allowing platelets to aggregate, because the 2b3a on the surface of the platelets is going to bind to the fibrinogen that the platelets released. That's going to form a series of cross-links between the platelets. This is platelet aggregation. The platelets start to aggregate and form a plug to temporarily stop the bleeding. So the activated platelet basically releases everything it needs to promote platelet aggregation. So that's how platelets work. And understanding these steps will help you understand the mechanisms of various antiplatelet drugs, which inhibit platelets at different steps in this process. Let's talk about antiplatelet drugs, starting with aspirin. Aspirin is a type of NSAID, so it inhibits the enzyme cyclooxygenase. Aspirin acetylates both COX-1 and COX-2, so it permanently inhibits cyclooxygenase, and that blocks the conversion of arachidonic acid to thromboxane A2. Now we said that thromboxane A2 will stimulate platelet aggregation. It's thromboxane, so it stimulates thrombosis. So if you inhibit thromboxane synthesis, you're going to inhibit platelet aggregation. Now since aspirin affects platelet function, a patient on aspirin will have a prolonged bleeding time, but PT and PTT are not affected. Lock that in. Bleeding time measures platelet function, not the coagulation cascade. Aspirin is used for a lot of different indications. It's used to reduce fever, it's used to treat pain, it's used as an anti-inflammatory, and it's used as an antiplatelet drug. We give aspirin to patients with an acute MI or acute coronary syndromes to block platelet aggregation and thrombosis of the coronaries, right? Or in an acute stroke. And we give low doses of aspirin daily to prevent MI. Now you need to be familiar with the side effects of aspirin. First of all, any drug that inhibits platelets can obviously increase the risk of bleeding. Inhibition of COX-1 in the GI tract can also increase the risk of peptic ulcers because you're not going to have the protective prostaglandins in the stomach. And you can possibly have some hyperventilation because aspirin directly stimulates the respiratory centers of the brain so that you hyperventilate and you get a little respiratory alkalosis. And we mentioned that when we discussed acid-base disorders in the renal section. But we also said that since aspirin is an acid, eventually that respiratory alkalosis might transition into a high anion gap metabolic acidosis. Another possible effect of aspirin poisoning and salicylate toxicity is tinnitus, or ringing in the ears. And there's also a side effect called Rye syndrome, which is why we generally don't give aspirin to children. Rye syndrome is a type of hepatoencephalopathy. Now, if you remember that name, hepatoencephalopathy, it's going to help you remember the features of Rye syndrome: liver problems and encephalopathy, and also hypoglycemia. Now, what's the one pediatric disease where we do give aspirin? I'll give you a hint. It's a disease that's associated with coronary aneurysms and then also desquamation of the hands and feet. It's Kawasaki disease. Kawasaki disease is one of the few times that we do give children aspirin. Another class of antiplatelet drugs are the ADP receptor inhibitors, or ADP blockers, which include clopidogrel, that's the main one. Then there's also ticlopidine and some newer ones like ticagrelor and prasugrel. So again, these are ADP receptor blockers. So think back to what the platelet ADP receptor does. When ADP binds to the ADP receptor, that induces expression of glycoprotein 2B3A on the surface of the platelets. So if you block that ADP receptor with one of these drugs, you're going to be blocking platelet aggregation. Now, clopidogrel is commonly given during an acute MI, or it can be given for 6 to 12 months following a coronary angioplasty with stenting. It's also used to prevent recurrent strokes. Or if a patient needs to be on aspirin, but he has an aspirin allergy, you might use clopidogrel instead. And then the last drug category of drugs that affect platelets are the glycoprotein 2B3A inhibitors. So there's abciximab, which ends in mab. That tells you it's a monoclonal antibody. And then the other 2B3A inhibitors are not monoclonal antibodies, and these are tirofiban and eptifibatide. So all these drugs block glycoprotein 2B3A, which was the surface molecule that binds to fibrinogen to cross-link the aggregating platelets. And make note that tirofiban and eptifibatide both contain the letters FIB right in the middle of the name, and that's going to remind us of fibrinogen. So the end result of blocking 2B3A with these drugs is that you inhibit platelet aggregation, similar to the way clopidogrel works, but these actually act on a totally different receptor and at a different step in the process. 2B3A inhibitors are used mainly for acute coronary syndromes, specifically the non-ST elevation MI. So for an ST elevation MI, you might give a thrombolytic like TPA or streptokinase, but for a non-ST elevation MI, you would consider giving a 2B3A inhibitor. They're also used during and after angioplasty. So now we're ready for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question, what's the lifespan of a platelet, which is also the maximum life of platelets after transfusion? It's 8 to 10 days. Next, what molecule is expressed on the surface of a platelet after it becomes activated? It's glycoprotein 2B3A. Next, NSAIDs inhibit the production of which substance important in platelet aggregation? It's thromboxane A2. And the last one, what's the mechanism of action of each of the following drugs? So we've mixed all the antiplatelet drugs and the anticoagulant drugs together in this question for review. So streptokinase is a thrombolytic, which converts plasminogen to plasmin, which cleaves fibrin and breaks down clots. so it lyses clots. It's a thrombolytic. Aspirin irreversibly inhibits COX-1. Clopidogrel blocks platelet ADP receptors. Abciximab is that monoclonal antibody that binds to glycoprotein 2b3a on the surface of platelets. Tirofiban also inhibits glycoprotein 2b3a. Ticlopidine blocks ADP receptors, just like clopidogrel. Enoxaparin is a low molecular weight heparin, which works by inhibiting factor 10A. And eptifibatide is a glycoprotein 2b3a inhibitor, just like abciximab and tirofiban. That's it for now. I'll see you next time.